Okay, so we are going to get going again, and we are going to start by a continuation of the session on tobacco use intersections with chronic health conditions, rurality, and sex. And our first speaker is Dana Carroll. I saw her making her way. She's been very patient. And so Dana, come on up. And Dana is an epidemiologist and certified tobacco treatment specialist with a research program that focuses on identifying what works for health disparity populations to quit smoking and informing the evidence based on regulatory approaches for reducing the appeal and addictiveness of cigarettes. In 2023 and 2024, she was awarded the Early Career Investigator Award from the National Institute on Minority Health and Health Disparities of the NIH, and the Jarvik Russell Award, an Early Career Investigator Award from the SR&T. That's a pretty good. You had a good year there. That's pretty good. And so she has contributed to several studies providing evidence base that reducing the nicotine levels in cigarettes is likely a highly effective public health policy for people who smoke and an opportunity for advancing health equity. And her presentation today is on very low nicotine cigarettes in a marketplace with alternative nicotine products. Are there differences in impact by participant characteristics? Dana?
Hey, good afternoon. So I joked with Eli that if you're still here, either you're interested or he paid you to be here. So I appreciate you all on this tail end of this wonderful conference. It's actually my first time in Vermont, and I'm just blown away with how charming and wonderful the weather is here. So just some brief disclosures. The research I'm going to be presenting on today received funding from the NIH. And I have no further disclosures. So what I often like to do is a land acknowledgement. So a lot of the work that I do, in addition to this work I'm interested in, is working alongside the American Indian tribes and communities in Minnesota and actually nationally as well. And so to me, it's always been really important to acknowledge the land that I have the opportunity to work and live on. And actually, Minnesota is a word that means where the water reflects the clouds. And Minneapolis is a sacred site. And this is actually a photo of my husband and daughter a few years ago, just a mile from our house. And so I often think about my positionality in the work I do and how I can help health disparity populations, and particularly the American Indian population. So I'm going to talk to you today about a potential nicotine standard in cigarettes. And so this idea was actually first conveyed by Neil Benowitz and Jack Henningfield, who was here at the conference yesterday, back in the 90s. And I learned from Jack that he was speaking with a regulator who asked, well, how much nicotine is needed in a cigarette to be addictive? And it really sparked this idea that he and Neil Benowitz talked about during a jog about lowering nicotine in cigarettes to very low and how that could be a potential way to get people off. So this is a bit of a busy graph, but there's been a significant body of evidence that has contributed to this idea that a standard in the cigarette itself to lower nicotine to very low levels seems to be a highly promising public health approach. And really, this became even more possible, at least in the United States, when Obama signed into law the Family Smoking Prevention and Tobacco Control Act. And in that includes language that nicotine can indeed be lowered as long as it's not zero. So since then, this Vermont group here, as well as the Center for Evaluation of Nicotine in Cigarettes, led by Drs. Eric Donnie and Dorothy Hatsukami, have contributed to a body of research that has really built upon each other as they've gone. And so some of the earliest studies were thinking along the lines of, well, how low should nicotine go to help people no longer crave cigarettes, help them make quit attempts, reduce the cigarettes per day, and with the eventual goal of smoking cessation. And so that was one of the first large-scale studies published in New England Journal of Medicine in 2015. And the conclusion from there that a level of about 98% lower, or 0.4 milligrams of nicotine per gram of tobacco, is the ideal low level. And this is compared to our typical, I always kind of don't like to say normal cigarettes because there's really nothing normal about a cigarette that kills, but our typical cigarettes around about 15 milligrams per gram of tobacco. Other studies are depicted here. Dorothy completed a study about a few years ago, right before I joined her as a postdoc, looking at should we reduce nicotine immediately? So in theory, the FDA could set a date, and starting on that date forward, only very low nicotine cigarettes would be available in the stores. Or do we gradually step down folks over time to the lower dose of nicotine? And that study concluded that an immediate reduction in nicotine would be most ideal in terms of biomarkers of exposure. However, there was a peak or a spike in nicotine withdrawal that was then followed by another study that I'm going to talk to you about today. So where we're at today is, I think the Vermont research that I know that there was a poster or two on, and then the Scenic study is really looking at trying to make these studies more generalizable to the real world marketplace. So cigarettes are not the only product. If you think of like tobacco as a balloon and you reduce cigarette use, what are people going to do? Although the ideal outcome would be to quit all tobacco, there are many other pathways. And so this is a study I'm going to talk to you folks about today. But before I jump into that, I also just want to mention that this has almost become a reality for New Zealand. There was a comprehensive plan to really curb smoking, particularly among the Maori population. It was really backed by the Maori, but they got new policymakers in place and this never went forward. That being said, we still have hope that in the future, in New Zealand, elsewhere, and the United States, that this is a policy that could be implemented and really save lives. So I'm going to talk to you folks today about the most recent trial led by Dorothy out of the Center for Evaluation of Nicotine in Cigarettes. I started working on this project as a postdoc and was part of the study startup to recruiting participants, and then the project finished up as I became a faculty member. So it's been a really exciting project to grow with over the years. This was just published in the Lancet journal this past spring, or might have been early summer. So per the title, the idea was to look at trying to mimic a nicotine standard in our real world marketplace with all these alternative products and do that in a study setting. So just in brief, what did the study entail? So these were folks that were the legal age to purchase tobacco. When the study started, it wasn't 21 at that point, the federal law. So there were some states that were 18 and up. They were daily smokers between 5 and 40 cigarettes per day. They were in generally good health, not pregnant or breastfeeding. And, I think an important component of this study is similar to, I think what Nancy was saying on some of her cytosine studies is we really wanted to bring participants in that would look like who our target audience is. And so we allowed folks to be using other tobacco nicotine products as long as they met the cigarettes per day criteria. So essentially there were 3 phases following the orientation and screening. So phase 1 was really just to monitor their baseline use of tobacco and other nicotine products. And so this involved turning on a daily phone call system where they received a phone call and they were able to put in the number of cigarettes per day, number of vaping puffs, even, if they were using nicotine patches, the quantity of each of those products the prior day. So we were able to get pretty granular data at baseline or phase 1. Then what we did is we tried to introduce them to the marketplace. And I'll talk to you folks a little bit more about what that looks like on the next slide. But really, we wanted to introduce them to this marketplace that was going to serve as like our mimic of the real world marketplace. So the first 2 weeks in that marketplace, or phase 2, they had access to their usual brand cigarettes and an array of alternative nicotine products. After phase 2, we randomized them to either keep that same marketplace with their instead of usual brand, now it was normal nicotine cigarettes, or they were switched to very low nicotine cigarettes as an attempt to mimic the nicotine standard. And this enrolled during the pandemic. There was a lot of troubleshooting that went on. We did evolve to many of our visits to, instead of being all in person, to be done virtually with a curbside component. And so we were able to continue and be successful. So the marketplace study. So essentially what we were trying to do is mimic like a kind of a online or retail experience. Participants actually navigated this website, and you can see they had cigarettes. And if this was the phase 2 or kind of the baseline phase for the intervention, this was their usual brand. Or once they were randomized, this either was normal nicotine cigarettes or very low. They didn't have access to their to the other one. And then all these other products that you see here. Participants actually navigated, they could learn about these products. We included vape products as well. And annually, what we did is we monitored and did surveillance of the marketplace to understand what were the most popular or frequently used products and types within those products. In other words, we really tried to mimic the real world marketplace as best as possible. Participants received points that reflected their baseline use coming into the study. So for example, if you were a participant that smoked a pack of cigarettes a day and that was it, you would get a set number of points that would mean that you could maintain that nicotine level in the study with purchasing products. If you smoked a pack of cigarettes, also did nicotine lozenges and maybe snooze, you got more points based on your baseline behavior. At first, when we started, we did not have nicotine pouches, but the whole kind of, I think what was really beautiful about this study was that it continued to be updated as the real world marketplace updated. And so, for example, Zyn, these nicotine pouches that we've heard about during this conference were introduced. And so we introduced those in the marketplace. Okay, I'm going to jump into some of the main study results, and then we're going to get into some of the moderator analyses that I think are going to be real of interest given the theme of this conference. So here are 3 of the main findings. In the top left corner of the slide is looking at change in cigarettes per day in the low nicotine group, which is the blue, and then the normal nicotine group, which is the red. And you can see over time, the folks in the low nicotine content group significantly reduced their cigarettes per day compared to the normal nicotine. We also looked at biomarkers because participants in the study were not just using cigarettes, they were using alternative products as well, and wanted to look at their biomarkers, the toxicant biomarkers. And so SEMA is a biomarker for volatile organic compound. And you see as well, really kind of mirroring the cigarette per day data, this went down as well in the very low nicotine content group. There were some other biomarkers that we looked at as well, like total NNL, like a potent lung carcinogen that tracked very similarly. And then the bottom graph is looking at CO verified 7-day abstinence across time. And you see that in the low nicotine group that this was significantly higher, even as early as week 4 into the intervention period compared to the normal nicotine group. One thing that I think is unique and tracks with the theme of e-cigarettes as a switching tool in this conference is that in both groups, those who achieved abstinence, the great majority of them were using e-cigarettes. So they switched from the very low nicotine content cigarettes to e-cigarettes. I will also say that the e-cigarettes came in all the variety of flavors to reflect the real world marketplace, and flavored e-cigarettes were most commonly used. We also had tobacco flavor in the marketplace, but that was less commonly used. Okay, so that's the main results that I thought would be just enough to catch you folks up to speed so that we could dive into the moderator analyses. So I'm really interested in whether policies or interventions differentially impact populations that tend to be left behind in the commercial tobacco control movement. And I think this really stems from, there's been a need to really analyze studies with a health equity lens to know perhaps which groups might need additional nudges or additional supports. So 4 separate moderators were of interest to us. We were interested in whether there were sex differences, age differences, and for this particular presentation, in my own interest, I was looking at the older adult age group. This is a group that tends to be kind of forgotten about in commercial tobacco prevention and control. We know that quitting at any age is beneficial, and so we focused our analyses on those 55 and up. Educational attainment and race, as well as huge, probably the key social determinants of health. So what's helpful for me is kind of just to break this down in a really simplistic visual here. And so why do we look at between group differences? I've mentioned this a bit, but when we think of a policy, we know that while there might be a positive impact for some groups, that might not be the case for all groups. For example, another group could have no impact or maybe a diminished impact. And so looking at these kind of health equity questions, I think is an imperative to us as public health professionals. And perhaps the lack of doing this in the past has maybe exacerbated our own health disparities. All right, I just wanted to provide a slide on some of the hypotheses for these moderators. It wasn't like we just, said, let's look at this, but there was a hypothesis behind each one. We've been talking a lot about sex differences, and so that was a great primer, some of the presentations we've had today. We thought perhaps because females tend to be less sensitive to nicotine effects, that cigarettes with very low nicotine, they may keep smoking those at a greater extent than men. So we were interested in looking at that as a moderator. Age, as I've mentioned, quitting at any age is key. And we know that quitting smoking for our younger age groups is trending in a good direction, but seems to be stagnant for our older adults. And what has been put forward is that perhaps lower use of switching or of e-cigarettes in particular among this population may be a contributor. And I think that's relevant given the findings that those, in the main results that achieved abstinence switched, they had switched to e-cigarettes. And so this was provoking from that standpoint. And then last but not least, the two variables that I think have the biggest implications for health equity are educational attainment and race. Just given the racism and how these are major determinants to health, to access to care, to health literacy, and so forth. So I won't get too much into the methods. This is a secondary data analysis of a main parent trial. I think for me, so my background's in epidemiology, which is always like a unique angle, being now more of a person who's interested in doing interventions. While that P of less than 0.05 is like hailed as everything, it's really kind of an arbitrary point of checkpoint that we use. So For this analysis, we were really looking for a signal, and we reflected on p-values, but also the magnitude of the point estimates when looking at moderation to kind of give us a big picture. We'll see if the reviewers of the paper fall for that excuse. Okay, so because this is a secondary data analysis, we were not powered to look at all of these moderator groups as we were in the main analysis. So it's important to reflect on the sample sizes because that's really going to potentially impact our precision. And I will say the groups are not tiny by any means. You know, I think especially for sex, we had certainly almost an equal distribution. You know, our older age group, and I think our Black and African American group had the smaller sample sizes, but they still had about 50 in each condition, which I think is adequate for looking at these as moderators. What's also glaring about this slide is that, for example, for racial identity, we have two groups. And so for me, I would love to be able to look at additional race groups, and potentially there's a way to do that through like a meta-analysis with multiple studies. Okay, so jumping into the results. So this is looking at the end of the trial. So these are after the 12 weeks of either access to the marketplace with the low nicotine cigarettes or the normal nicotine cigarettes. What were they doing at the end? And this actually shows that the VLN group, so these are all negative, had a reduction in CPD, cigarettes per day, versus the normal group, normal nicotine group, you know, really reflecting the main trial. And this was consistent across all of our moderators. And looking at the magnitude and the p-values, we really did not see any signal for moderation in this outcome, that they all reduced on average cigarettes per day. This is a second, this was a second primary outcome in the main analysis, looking at smoke-free days during the intervention period. And just to orient you, essentially, for example, for female sex, the incident rate for smoke-free days in the VLN, the low nicotine group, versus the normal nicotine group was 3. So you can see this ranged from about 3 to even up to 8. There's some variability, as you see in those confidence intervals, given the sample sizes, but all were in a promising direction, benefiting more smoke-free days, with one notable moderation that we detected, and this was actually significant at 0.05, and then you, as in terms of the interaction term, but then also you can see that there is a pretty good drastic difference in the magnitude. So those of the younger age group achieved the smoke-free days of a rate ratio of about almost 6, where those of the older age group only achieved about 1.8. So nearly similar between the low nicotine group and the normal nicotine group. We'll come back to this. So this is looking at SEMA, the geometric mean ratio. This is a biomarker. Again, this is at the end of the study. So we want these numbers to be small. So closer to the further from 1, the better the low nicotine group did, right? So across the board, all of the point estimate, the ratios are less than 1. However, we do see there's that older age group where they're hovering close to 1. It's different than their counterparts that are less than 55 years. And that was a statistically significant moderator. The education group, we saw what I would consider a signal where it's worth diving into further and thinking this through in terms of additional supports. Those of the lower education group also tended to not achieve the reduction in SEMA in the low nicotine group versus the normal nicotine group to the same extent of their counterparts. They're all benefiting just at greater amounts in the higher education and the lower age group compared to their counterparts. Okay, so I think this slide helps understand these data points. So this is now looking at the end of the study and is looking at what products people were using. And the dark gray is folks that continued using combusted products or the normal nicotine cigarettes or the VLN cigarettes. The light gray is dual use, and then the maroon is what we considered, successful in terms of our endpoint here, where they were either only using non-combusted products or they were not using any tobacco or nicotine. And you see some for the older age group and those of lower education, they were less likely, around only 7 to 8% in the VLNC condition achieved that kind of what we consider that ideal outcome. And so I think what this is really showing us is these groups potentially need additional supports to nudge them into that maroon bar. What this also shows is a nicotine standard is, at least on its own, like how we did in the study, is not a silver bullet. I think that's a takeaway from most all of our interventions, that we are learning how to do better, but I still think we can do more. And so one thing I just want to draw our attention to is the dual use is quite high throughout the study. Okay, wrapping up. So what does this all mean? So for me, this means that there is evidence that the older age group, we would want to think about additional supports and nudges, particularly for these individuals. And I would also go to say that that would be probably the case for those in lower education, that there was a signal that they may need additional supports. So what we did is a post hoc analysis and essentially looked at on the left side, these are the older age and the lower education is the groups that we felt needed more support from the results. They, I think, just have a different set of social norms. So both those of older age and lower education had a ratio of 3 for the number of close friends they had that smoked to used an e-cigarette. So using an e-cigarette in their social circle was less normal than the other two, than their counterparts. And so I think one interpretation of this data is, well, we did not fully mimic a nicotine standard because it was only the participants in the study who were subject to the low nicotine cigarettes. They would go home, they would be around their social circles who were still smoking normal nicotine cigarettes. So perhaps in the real world implementation, when everyone is subject to a nicotine standard, everyone is subject that smokes, the social norms would not be as big of a concern of continuing smoking in the older age and lower education group. The other interpretation that I say we could take is that there are likely a need for additional supports in this group. So, final slide. A nicotine reduction standard, even though we did see moderation, the results were highly suggestive across all groups that a low nicotine standard is beneficial. However, for some of our groups, the benefits were less so than others. And in particular, the older age and lower education. Dual use was still common as well. So I think, as I've mentioned, this is really not a silver bullet, but a nicotine standard, if implemented, could be part of a comprehensive plan. And I think a next step, and one that we should really consider, is layering on education and promoting quit smoking resources. This was not done in this study that I'm describing right now, but I think would be a next step that would be really interesting to look at. Part of that education could be in alignment with the FDA's website on educating folks about the continuum of or the relative risks of tobacco products. And this might be particularly helpful for getting folks to completely switch over to e-cigarettes if they're not interested in quitting. Okay, I think I took up a lot of time, but here are my acknowledgements. We have Eric Donnie sitting in the audience, who led the Center for Evaluation of Nicotine in Cigarettes with Dorothy. And this is the team. It was a great effort. We had sites at Duke, at San Francisco, at Brown, at Penn, and Wake Forest. And so I stand here as part of this team, and I'll be happy to take questions later.
Right. So Our next speaker and our final speaker in the list, the Eli's a great guy. He is willing to be the final guy. He's going to be speaking on the frequency of e-cigarette use as a mediator of effects in 3 randomized controlled trials of reduced nicotine content cigarettes with tobacco versus preferred flavored e-cigarettes in high-risk populations. So, background on Eli. Eli is an assistant professor of psychiatry and psychological science here at the Vermont Center on Behavior and Health in the Larner College of Medicine, University of Vermont. As a behavioral scientist and licensed clinical psychologist, his research broadly falls within tobacco regulatory science and tobacco control. He primarily focuses on nicotine reduction, dual use of cigarettes and e-cigarettes, and interventions for people who are not yet ready to quit smoking. Dr. Klemperer uses a range of research methodologies, including clinical trials, controlled laboratory studies, meta-analyses, and a fine-grained naturalistic research. He has experience conducting both fully remote and in-person trials. In addition to his work in tobacco, Dr. Klemperer has an emerging line of research examining the treatment of opioid use disorder among people who are incarcerated, which reflects his clinical work in correctional settings. As the Associate Director of the Vermont Center on Behavior and Health, he oversees 2 pilot project programs which support fellows and junior faculty in conducting pilot research to seed future NIH funding. He's the primary mentor for 1 clinical psychology pre-doc, serves on multiple master's thesis and doctoral dissertation committees, works regularly with pre- and postdoc trainees within the VCBH. He received his PhD in clinical psychology from the University of Vermont and completed his clinical internship at Yale before returning back to the University of Vermont. So, Eli.
Thanks, Steve. And thanks everybody for sticking around to the end in the audience and also those who are still online. Appreciate it. So as Steve mentioned, I'll be talking to you about a secondary analysis of the TCORS trials that were led here by Steve and colleagues at the University of Vermont. Here's my funding. This was funded by the UVM TCORS and nothing to disclose. So before I get started, I'd like to acknowledge collaborators and co-authors. This was a huge team effort to pull off these trials, and I was grateful to get to be a part of it and work with such a great team here at UVM and at Johns Hopkins and at Brown. So in the way of background, much of which has already been covered, which is great by other talks in this conference, as well as in Dana's excellent talk before me. We're all well aware of the harms from cigarette smoking. And has been covered by talks so far these past 2 days. Smoking is dramatically overrepresented among people with psychiatric conditions and low educational attainment, which are the populations that we're focused on in the trials at UVM TCORS. So to reduce smoking across the US, the FDA has announced plans to limit nicotine in cigarettes to minimally addictive levels, which Dana went into some great detail on earlier. So I will skip on to my next slide. The research that I think was really nicely shown in that timeline in Dana's presentation very clearly demonstrates that such a standard would have tremendous effects on the public health in the US, decreasing smoking frequency, toxin exposure, dependence severity. And importantly, so far, these effects have appeared largely consistent across populations. So here at UVM, we've focused on a number of vulnerable populations and been able to also produce the benefits that you see there on the screen. So these are just a couple of papers that were highlighted in that timeline demonstrating these effects, but it's consistent and robust, which is very exciting. So on to the background for this specific secondary analysis. The success of a nicotine limiting standard, as was discussed, may be conditional on the availability of non-combusted products, and specifically appealing non-combusted products for those who are unable to quit nicotine altogether. And so this gets back to a topic that's been discussed at length here and in other settings. Though not without risk, e-cigarettes are very likely are less harmful than combusted cigarettes. So what that means is if we can switch people over from combusted to non-combusted, this is harm reduction. Or if we have dual use, if we see a reduction in cigarettes per day, this has also been demonstrated to reduce biomarkers of harm. So importantly, for some context, there are a range of appealing products on the market, including e-cigarettes in a variety of flavors. And regulation from the FDA has limited the authorization of e-cigarette products in appealing flavors, sweet and fruity flavors, to protect youth and to try to curb the increase in e-cigarette use among youth, which is very important. But this may have implications for people who smoke cigarettes and their likelihood to switch to non-combusted products, which was really the focus of the RCTs conducted as part of the UVMT course. So those parent RCTs were 3 parallel 16-week trials focusing on whether preferred flavored e-cigarettes selected from a range of appealing options enhance the benefit of very low nicotine content cigarettes. Importantly, especially for this conference, but also for the literature, there were 3 populations that were targeted in these 3 parallel trials: adults with affective disorders, adults with opioid use disorder, and reproductive age women with less than high school education. As has already been discussed, these results were published in JAMA Network Open, I think just about 1 month ago today. And if you haven't read it, I highly suggest checking this article out. But I will give a summary, so you'll get the brief report here. So importantly, the participants were randomized to 4 conditions in each of these 3 parallel RCTs. I'm using the word normal, although I really like your explanation here. There's nothing normal about a cigarette, but the standard is to call these NNCs, or normal nicotine cigarettes, reflecting the nicotine concentration as commonly available on the market. So that was our first condition, our control. Second condition was to randomize participants to very low nicotine content cigarettes. These are the same cigarettes that have been used in the Scenic trials and the presentation just before me, with minimally addictive low nicotine content. But then the third condition, we randomized to these same low nicotine cigarettes, but also provided Juul e-cigarettes in tobacco flavored pods only. So representing the most current products, e-cigarette products that have received authorization from the FDA. Until recently were only tobacco flavored. Now there's a menthol as well, but sort of showing that limited range of flavors available under FDA authorization. And then the last condition was our real experimental condition: low nicotine cigarettes, Juul, but participants got to choose between a range of appealing sweet, fruity flavors to use during the duration of the study. So the flow is what you see here on the screen. There were 326 participants in total. That first column there is normal nicotine, so that was 83 participants. VLNC stands for just the VLNC cigarettes, no e-cigarettes. Then 74 to VLNC cigarettes plus TF, which stands for tobacco flavored e-cigarettes. And then that experimental condition, the 84 participants randomized to VLNC cigarettes plus PF, or preferred flavored e-cigarettes. So the main take home from that paper that was recently published last month is what you see here on the screen: total cigarettes per day. And it's important to note that these were all participants who at baseline were not using e-cigarettes regularly. They could have had some experience, and they were not motivated to quit at baseline. So our primary outcome was total cigarettes per day. Orient you to the graph. The vertical axis is mean cigarettes smoked per day. Horizontal is the weeks in the study. And that blue line at the bottom there is the VLNC plus PF condition, or those who got low nicotine cigarettes plus preferred flavored e-cigarettes. And you can see this had the greatest reduction in cigarettes per day, which was exciting to see. This was reflected with biomarkers of harm, expired carbon monoxide, as well as NNAL, which, as discussed earlier, is a biomarker of harm. Okay, so moving on to the present secondary analysis, which was a mediation analysis. This was, the idea behind this mediation was really fueled by these observational studies that have been summarized nicely in a meta-analysis by Wang et al., demonstrating that there's a pretty strong correlation where greater frequency of e-cigarette use is associated with greater reduction in smoking. This has been shown in a number of studies across different nationally representative data sets. So it would make sense then that the mechanism of action here might be that having a more appealing e-cigarette would result in a greater frequency of use of e-cigarettes. Greater frequency of use in e-cigarettes would decrease cigarette smoking. So this was the premise behind the mediation analysis here. Important for a number of reasons. One, because it demonstrates a mechanism that drives the effect of FDA policy, but also it starts to get one step closer to causality, where we actually have people who are randomized to appealing e-cigarettes versus a single flavor. So it helps us determine whether that link between frequency of e-cigarettes and frequency of smoking might actually be causal, whereas observational studies tend to show the correlation. So to conduct this analysis, we used 2 of the 4 conditions that were given e-cigarettes, the tobacco flavored or preferred flavored e-cigarettes. I'll briefly walk you through the analyses. So we used a series of regressions to test preferred versus tobacco flavored e-cigarettes first as a predictor of e-cigarette use frequency. So there are a number of ways you can talk about frequency of e-cigarette use between days, within days. Here we use 3 different measures of e-cigarette frequency. The take home here is that all 3 showed very similar results, so I won't get into analyses for all 3, but we did look at it with mean cigarettes per day, mean days of e-cigarette use during the study period, then an absolute percent of days when e-cigarettes were used as a measure of frequency, and then a binary split where did participants use on 80% of days or more, or less than 80% of days. We then took e-cigarette use frequency between weeks 1 through 15 of the study and tested that as a predictor of cigarettes per day at week 16. And we capped frequency at week 15 so we could have a temporal precedent in the mediation analysis, again, trying to get at that causality where the frequency occurred before the outcome of interest, which is cigarettes per day. And then finally, we conducted a full mediation analysis, first looking at direct effects. So replicating what we saw in the primary outcome, preferred flavor as a predictor of cigarettes per day, and then adding in e-cigarettes to the model to see if it mediated that effect. All analyses controlled for study population, baseline cigarettes per day, age, sex, and then experience with e-cigarette use at baseline, even though they were not regular e-cigarette users at baseline. But we did then conduct some moderator exploratory analyses where we pulled sex and age out and looked at those specifically as moderators of this mediated effect. So it gets a little complicated, but for the sake of discussion today, we figured we'd add a little bit more, and then did the same with baseline cigarette dependence. So to walk you briefly through participant characteristics, participants were between the ages of 39 and 42. Most were women. This is because one of the studies focused entirely on women of reproductive age with low education attainment. We had about 19 to 30% who identified as non-white, and a little over 60% who had a high school education or more. Participants smoked between 17 and 18 cigarettes per day, were moderately dependent, and worth noting there at the bottom that between 7 and 16% had some prior history with e-cigarette use, but we did control for that in analyses. Okay, so first looking at this A path, did preferred e-cigarette flavor versus tobacco e-cigarette flavor actually result in greater e-cigarette use frequency? And the result was a pretty consistent yes over time. So that blue line, those blue dots represent those who received preferred flavored e-cigarettes. Green represents those who received tobacco flavored e-cigarettes. And you can see about a day or two more of use per week over time throughout the duration of the study. And that was significant over time. So on to the second half of the model here. Did frequency of e-cigarette use, regardless of condition, predict number of cigarettes smoked per day at week 16? And again, what we see here is yes, it did. So to orient you to this graph, the vertical axis is mean cigarettes per day smoked at week 16. That blue bar on the left is the portion of participants who use their e-cigarettes on 80% of days or more during the study period. Green bar on the right is those who use their e-cigarettes on less than 80% of days during the study period. And you can see a pretty dramatic difference, about 5 cigarettes per day in the group that use their e-cigarettes on 80% or more of days, as opposed to around 15 cigarettes per day on those who did not have such a great uptake of e-cigarette use. So on to look at the mediation model. First, this is just simply replicating what was reported in the primary paper, that yes, there was a direct effect where providing preferred flavored e-cigarettes predicted a reduction in cigarettes per day. However, the interesting thing, which you may have already guessed, is when we add e-cigarettes to the model, that effect is completely eliminated, indicating full mediation, wherein frequency of e-cigarette use is at least a mechanism driving this effect of preferred e-cigarette flavor on cigarette reduction. Okay, so then we just took it a step further and saying, well, what about some moderators here? You know, did flavored e-cigarette affect frequency of e-cigarette use across sex, across age, across dependence, or did it really only increase e-cigarette use among certain subpopulations? And when we look at those moderators, we see no effect for sex pretty clearly, although I'm really glad you set me up with the p-values, Dana, because we have some marginal effects here, some trends. I decided to go ahead and explore them anyways because I was just curious. But Dana has justified it, so we're all good. So looking into age and cigarette dependence, again, noting this is not statistically significant, but we're underpowered. These are trends. It's good for discussion. What we see here might be an effect where those younger adults, age 21 to 40, represented by the blue squares, appear to have more of an increase in e-cigarette use with the preferred flavored e-cigarettes, and less effect for the tobacco flavored. So age 41 to 70, we see about 40 to 50% of days when e-cigarettes were used, regardless of if they received preferred or tobacco flavored. But age 21 to 40, we get up into the 60% range on the left there with preferred flavored e-cigarettes, and then down to really the 40% range with tobacco flavored e-cigarettes. So it might be these younger folks, as you might expect, that are most affected by these flavored e-cigarettes. Then moving to the right panel, dependence, again, marginally significant trend here. But again, those with higher nicotine dependence, so a score of 6 to 10, getting about 40% of days when e-cigarettes were used, regardless of the flavor, whether it's preferred or tobacco flavor. But it's those lower nicotine dependence, again, this is baseline dependence, where we see the increase up to about 60% with preferred flavor e-cigarettes, and then really same around 40% with those tobacco flavored e-cigarettes. So it could be maybe that younger people who are less dependent might be driving some of the effect here that we see in the mediation analysis. Okay, so what about mediation on the other half of the model here? Or sorry, moderation on the other half of the model here. So did the effect of frequency of e-cigarette use on cigarettes per day differ by sex, age, dependence? And I think the good news here is no. It appeared that really, if you can get people to use e-cigarettes frequently, it drives down their cigarette smoking, regardless of sex, age, and their baseline nicotine dependence, which I think is useful information. Okay, so quickly some considerations. First, I included this, well, first is that this is a secondary analysis limited to 2 arms of a larger RCT, so really exploratory analysis here. Second, this is not necessarily a limitation, but something to keep in mind. All participants receive VLNC cigarettes, so has policy implications, and I think has implications just regarding e-cigarette use, even in the absence of a policy, but we need to remember that all participants did receive VLNC cigarettes. Also, these studies were also conducted during the peak of a COVID-19 pandemic. Strengths, these were large multi-site RCTs in 3 vulnerable understudied populations. We saw convergent validity across multiple measures of e-cigarette frequency, which always increases my confidence in the data. And then at least on one half of the moderator analyses, findings were robust to moderators, indicating that, you know, if people increase their e-cigarette frequency, regardless of where they are in terms of baseline dependence or their sex or age, we can expect to see some reduction in cigarettes per day. So last slide here, and then I'll end. But the recent RCTs, as a summary, indicate that access to e-cigarettes in commonly preferred flavors could enhance the benefits of a policy to limit nicotine in cigarettes. And these mediation findings indicate that it might be increased e-cigarette use frequency that's really driving this, or at least one of the mechanisms driving this effect in reduced cigarettes per day. This helps to support a causal relationship between frequency of e-cigarette use and reduced cigarette smoking, and suggests that interventions which increase e-cigarette use frequency among adults who smoke may maximize harm reduction in this population. So it's not simply providing e-cigarettes or reduced harm products, but it's making them appealing in an array of flavors or an array of products that might help drive use up and drive smoking down, which is the ultimate goal here. So with that, I will end and I'll hand it back to Steve before taking questions. Thanks.
Yep, so just turn your mics on. All right, so these papers are open for questions, comments. Yeah.
Hi, as somebody who collects data on e-cig use, I'm just curious how you mentioned like using a phone to ask question, I think every day. I'm just wondering, like, so then does that just get you, they used it today, yes or no? Like, do you ask how many times you used it on a day? Or can you say more about what kind of information you end up getting and how you get it?
Yeah, it's a great question. So yeah, at this time, I think now we're thinking more about a text-based system that does the same thing. But when we did this study, it was a daily phone call. And when asked about e-cigarettes, it was only turned on if they were using e-cigarettes from our marketplace or if they were using that at baseline. But they could have the option to report a product they're not being asked about. We could catch it there. But they would report the number of puffs that they took during the day. So we do have that level of data. I do not think we've looked at it thoroughly yet. The other part of the data that we did collect, which I think is interesting, is we weighed the, so we actually did product accountability. So there was 4 types of products, the views in the Juul. And so we could actually count cartridges used. So that was another way. And then for the like all-in-one pen, and then there was more of a pen style one as well, we actually weighed the e-liquids. And again, I don't think we've looked at that data, but I think it's pretty nuanced level of data that we collected. And so every time they come back in, we would weigh it, we would check what they have left. So that's how we
Did you weigh them before they went out, each one?
the tank systems we did.
Okay.
Yeah.
So if they were like packaged, you'd have to take them out of a package and weigh it before.
Oh, I see. Good question. No, we assumed the standard weight of the package. So we didn't have to open it each time, but we figured if they fill up with e-liquid, the bottle was, if it's not been opened, it's the same weight each time. So it was just when they returned it.
Yeah, one problem we're having with prepackaged product is that they're not the same weight.
Okay.
You can take them out of the package. I don't know if you've seen that, but
Yeah, I'm
you
sure
can take them out of
there's-
the package and there's variability
Yeah.
in how much they weigh, even when you take them out of the cardboard and just sit the stick on the scale.
Yeah, no, I understand too, even there's some contradictions with what's on the label as how much nicotine is in these products. So this was definitely more of kind of an exploratory part of the study and not part of like the main outcomes, but yeah.
One other quick question for you. So when you had that first period where people were sort of like reporting on their cigarette use, were you worried at all that people would start smoking less because they're like being prompted to say how much they're smoking? Do you know what I mean? Like, did that serve at all as like an intervention or not really?
Yeah, I think that's an interesting question. I mean, I guess the good thing is that would have been the case for both groups. And so that by randomization in itself, it kind of helps. One thing that was interesting that actually Joni Jensen, who's worked a long time with Dorothy and with participants, recognized is, say your participants are going to come in 2 weeks, right? The few days before they come in, they do start to use less product because they've already used it up and they know they're coming in, or, so when we would use the data for like their baseline or use, we would use it except for those 4 days before their visit. So
Mhm.
it did drop.
It did. Okay.
Yeah.
Can you talk about how you measured e-cig use?
Yeah, it was a very similar protocol. So we did, I think Steve could probably fill you on, but almost the exact same thing in terms of measuring the pods, asking about puffs per day, and nightly or daily phone calls to ask about whether.
Were those live calls or text?
An interactive voice response system. So it was an automated phone
bot?
call,
Okay.
essentially. Yeah.
I get a piece of data that we just happen to look at that I won't go into why, but regarding whether people might be self-conscious about reporting their smoking rate. So we have at baseline, we ask people how much they anticipate smoking if cigarettes were free. If your preferred cigarettes were free, how much would you smoke a day? But then these studies are unique, and we did two big randomized controlled multi-site trials like this, where we ask them that question, and then we actually give them free cigarettes for 1 week. And in both trials, the people overestimate how much they would smoke if cigarettes were free. So it doesn't show any sign of being like shy about saying how much they smoke.
Mhm.
I think it's they underestimate satiety, or, so it's kind of interesting. They overestimate by around, in both trials, an average of 4 cigarettes a day. So.
One other thing I'll mention, assessing e-cigarette use within a given day is just really hard.
Yeah.
And so in this, and full of problems, but in these next studies that are upcoming in our center, I'm moving toward asking the single question from Jonathan Fold's Penn State e-cigarette questionnaire or nicotine questionnaire, and where he defines a period of use as, I think it's 15 puffs or 10 minutes, but you can look it up, it's online, and that's sort of what we've settled on going forward.
A session.
Yeah.
Thank you all for your presentations. So my question's for Dr. Klemperer. It's actually about the measure of dependence. So I was wondering, is the Fagerstrom that you used a test of cigarette dependence, or okay? And is there also, I feel like I should know this, is there also a measure of e-cigarette dependence in the data set? And did you look at that as well? And then my final part of this question is, have you looked at, or do you plan any analyses to look at whether cigarette dependence and e-cigarette dependence change relative to each other over the course of the trial, and whether that might have any effects?
Those are really good questions. So first, cigarette dependence. So is the FTND, also known as the FTCD, but testing cigarette dependence specifically at baseline. I think the important thing to remember is these were all people who were exclusively smoked cigarettes at baseline. Some had tried e-cigarettes or used them occasionally in the past 30 days, but for that reason, I don't think e-cigarette dependence was assessed at baseline. I think it was assessed going forward. I'm not sure, but I think the analysis you proposed, if it was, would be an interesting one to see how e-cigarette dependence develops and how that compares to cigarette smoking in this group as cigarette smoking declines and e-cigarette use goes up.
Hi, thank you guys so much for your talks. It's given me a lot to think about as I'm also, I'm new to the tobacco regulatory research, so it's really exciting to hear about all of these analyses. My first question is for Dana. So you mentioned that for the older adults, it might be beneficial to provide those additional resources like education and referrals. So do you recommend that future studies look at supplementing the reduced nicotine content cigarettes and the other alternatives with those educational tools, and that you look at that in some sort of randomized clinical trial, or maybe other studies have looked at that and I haven't come across that yet, but what are your thoughts on that?
Yeah, that sounds like a great trial. Yeah, I think that would be really interesting. I think too, because if we think about we think the future is going to be potentially educating about the relative risks of tobacco products. It would be interesting to know, how much more does a nicotine standard add to that? I think based on the data that we would think it would be really important, but it's an empirical question that I don't think anyone's addressed at this point. So yeah, I could see a clinical trial where both groups get maybe some of the digital cessation resources. Maybe you could even think about completely discounting the NRT as a way to help nudge further to that group, and then layering in the relative risk messaging. So that sounds really interesting.
Great, thanks. And then my next question is for Eli. I don't know if you mentioned this, but when you were showing the bar graph and you were comparing the groups that had like the less than the equal to or greater than 80% of days for use of e-cigarettes, and then the less than or equal to 80% of days for use of e-cigarettes. Was there a constant between the tobacco flavored e-cigarette group and the preferred flavored e-cigarette group? Was there a difference in how those groups were distributed across those categories? And were the preferred flavored, did they tend to use I would assume they tended to use the e-cigarettes more? Or they were in that 80% or more group?
Yes. So the prior slide showed the difference in e-cigarette use frequency, but it was a different measure of e-cigarette use frequency. So I have those data, but they were not in my presentation.
Okay.
I can tell you that the total sample was split up about 70. I think it was about 70 participants used e-cigarettes on 80% of days or more, whereas 90 participants around there used e-cigarettes on less than 80% of days. But what I can't tell you right now, but I can tell you after the talk, is how that was distributed between the preferred versus tobacco flavored e-cigarette flavors.
Right. My hypothesis is that the preferred flavor groups, they tended to use the e-cigarettes more.
Yeah, that's true.
I don't know without seeing the data, but that's my hypothesis.
That's true. And that relationship was significant, but the exact distribution, I didn't include there.
Oh, gotcha. And then sorry.
Finish your question.
I just have one other question. And it's kind of broad. It's more big picture, I guess. A lot of trials at this point have demonstrated the effectiveness of reducing nicotine content and reducing smoking prevalence across a lot of different groups. But at what point would we say that we have the necessary knowledge and resources available to inform a nicotine reduction policy? Would we recommend that a nicotine reduction policy be implemented as soon as possible, just for overall public health benefits? I mean, I know that's not in your control.
Answer that.
I imagine that we would recommend that be implemented as soon as possible, right? And if that were to happen, I imagine that what might the research look like when the nicotine policy may be implemented, I guess. I know it's a very broad question.
No, it's good. Broad questions are good.
Big picture.
So I think the body of evidence is strong. It's robust. It's shown, as in our presentations and others, that there's benefits for the population studied. To me, this should not be delayed, and we do have the evidence to implement it. However, I would say that there are questions that the industry is going to pose that we could add more research to in the interim if it's not here today. I mean, I think what I raised about, if we're going to educate about the continuum of risks, how critical is a nicotine standard? Can't we just let consumers be educated and pick their product is one. So I think that is, I think we haven't gotten the menthol ban implemented. So that seems to be an obvious step, and that's taking a while. So I imagine a nicotine standard in the reality is still probably 5-10 years away in the United States, if that. So I think there are additional studies, for me too, I'm kind of interested in more nuanced data on cannabis now that it's been legalized in a lot of states in a way that is different from how these studies work when they were conducted. So kind of back to the balloon analogy, when we reduce tobacco use, what are these other impacts on cannabis and alcohol? And so I don't think that it's needed to be implemented, but it's a good question to also come back to the industry with and have some potential concerns mitigated, or if there are concerning impacts, to be able to be prepared for that. And then I would say the last thing that I would recommend is that we have very sophisticated surveillance. So when this goes into effect, what are the product use trajectories? How does the landscape change? Who is being left behind, and what unintended consequences there are? Because at the end of the day, we can only act on the data that we have, which looks very strong, but certainly things may play out that we might not expect, so that we can monitor those.
Just to add one more thing, I really appreciate that question because it's very comfortable to do this kind of research. It's fun. It's exciting. You get these robust effects because it's an effective policy intervention. And then it's in a completely different question to say, well, now what? Which is what you're asking. And I can comment on the data, the methodology, and then as soon as we move into and now what, hope we have colleagues that can help us with that.
Yeah, I would just say, it's a big decision, and I'm glad it's not my decision about whether you move forward with that policy, because there's so many potential unanticipated ways it could go wrong. On the other hand, if I had that charge and I had the evidence in front of me, if that is, the charge is bigger than just what to do about cigarettes, it's to protect the public health from cigarettes and other tobacco products. And the evidence is overwhelming that the more nicotine in the cigarette, up to the limit we studied, the more smoking you're going to get. So given the carnage that smoking causes on the population health, I would be very uncomfortable doing nothing. In fact, I think you can make a case that that to do nothing is to kind of is irresponsible in terms of protecting the public health. I think that's overstating a little bit, but that's how strongly I think the carnage, when I think of the carnage of smoking and the evidence that of the influence of nicotine on the smoking rate, which is a big predictor of the likelihood of being able to quit, and dependence severity, which is also another major predictor of the ability to quit. The evidence suggests you should do something in that direction. And one last piece is we know that if you're squeamish about how much you reduce it, you might generate compensatory smoking, which has its own adverse effects. So if you're going to do it, you should go as far down as the data suggests, which is very low. So those are another thought, but you're hearing a range of thoughts. And Brian King or some other person is going to have to make those decisions. Right. But I think they're really important. And we were all thrilled when the Obama administration finally gave the FDA regulatory authority, and this is an opportunity to do something important.
Great. Thank you so much.
Conrad.
Thanks for your presentations, and I'm going to have to find this 2024 study that's just been recently published, and the effects look impressive. And so that being said, have you all thought about the fact that the results are so robust with regards to your harm reduction approach, but I think you're also very close to helping a lot of individuals potentially achieve abstinence. And so maybe two questions. One being, have you looked at those data to see whether anybody out during follow-up do achieve abstinence and if there's an effect, would that be a way to help bolster your position about the importance of harm reduction? Because no one can argue about the fact that the benefits of abstinence, right? I mean, that's well established. But then the other question, to take your maybe this intervention to the next step of you're getting this much harm reduction. What is the next element that's necessary to help them to get to abstinence?
Well, yeah, so I think that those are very important questions, and staying rooted in cigarette abstinence is critical, because that's where we make change. So first, important to note that these at baseline were all people who are not motivated to quit. And I think that is driving some of the results you see here. These are, they were very clearly not ready to quit at baseline. I don't know if I haven't looked at the abstinence data. I know it is in the data set. I don't know.
But look, it's not good. I mean, we don't get an effect in our study in terms of quitting when we follow them up. But it's the confounding factor, or the limitation, is that we selected people who explicitly said they weren't planning to quit in the near future. And so there are reasons that we had that characteristic, that criterion. Going forward, it would be good to do similar kinds of studies in either a sample that's more representative of the smoking population, many of whom, I don't know, all say vast majority say they want to quit sometime. And I forget off the top of my head what proportion say soon, but get them either all who are thinking about quitting or a better cross-section. But for a number of scientific reasons, these initial studies have been done in people who weren't planning to quit. Otherwise, it could screw up the data because you got people quitting for reasons other than your independent variable.
Yeah, and if I can add, I presented it first on the main results of the marketplace study out of the Center for Evaluation of Nicotine in Cigarettes. And so we did look at abstinence, biochemically confirmed abstinence, and it was so this is a study that had access to e-cigarettes and flavors, and that tended to be how most of the folks did achieve abstinence. It was about 18% in the low nicotine group. So the prior study that was done by Dorothy just only had low nicotine cigarettes, no access to these alternative products. And while it had higher abstinence, it was less so than in the study with the alternatives. So to me, while it wasn't a direct comparison, it aligns with, the story that for achieving abstinence for folks, it really, for most of them, is achievable by the switching to a non-combustible, and particularly the e-cigarette, the flavored e-cigarette. So, yeah.
So I don't know if your question was about follow-up. I thought it was about people quit after the study. During the study, there's a huge effect for more days abstinent in the people who had the preferred e-cigarette.
And there is a secondary analysis of one of the Scenic trials where at follow-up 30 days afterward, those who received VLNC cigarettes had greater prevalence of smoking cessation. I can't remember the exact percentages, but
Yeah, I think another interesting angle is if the nicotine standard is kind of a pie in the sky, what about low nicotine cigarettes as a potential cessation aid to come alongside participants or real world patients? So.
Yeah. So I've kind of noticed throughout this conference that there's kind of been a theme that e-cigarettes have potential as a harm reduction strategy. And I'm really actually very impressed by the results that people with no intention to quit are actually showing reductions in smoking. With that being said, I'm kind of curious, sort of to your question, what the end game is here. Because if people are transitioning to e-cigarettes And I personally do want to push back against the generalization that they're safer than cigarettes because it's a very unregulated market and these are unstable pyrolysis devices with sometimes hundreds of chemicals in them and heavy metals, which sometimes act as catalysts to release other chemicals as well. So I think we should be cautious about generalizing. But if we're working with that assumption and people's transition from combustible cigarettes to vaping, the harm is reduced. But is there an end game there? Because as we know, they have a lot of the same chemicals that do cause maybe cigarette-related lung cancer, other chronic health issues, and it doesn't seem like they would necessarily just go away
Sure.
if people switch. So I'm just curious what your thoughts are on that.
Well, I think those are very good points, and thanks for bringing them up here because it's not always easy to voice that when you hear, other people speaking about e-cigarettes. And first, the point comparing harm from e-cigarettes to combusted cigarettes, it's an empirical question. And I think smart people can look at the same data set, come to different conclusions. When I look at the data, it's pretty clear to me that if you take just using e-cigarettes compared to combusted tobacco, e-cigarettes are far less harmful.
Sorry, when you say e-cigarettes and I'm just curious, the studies that you're looking at, are these on FDA approved products or what? Because just the market is so unregulated right now. I don't know. I'm just trying to get a
Yeah.
picture. Yeah, sorry to interrupt.
Typically nicotine salt or products. But then your second question about what next? So people are using e-cigarettes. Ideally, they've stopped using combusted cigarettes. And I think that's an important question. And I know there's a lot of work being done right now on e-cigarette cessation interventions. Nancy Rigotti presented some really exciting data at the beginning. And I think the key when we're thinking about transitioning people to being completely abstinent from nicotine, which should be the goal, is to ensure that there's no return back to combusted cigarette smoking, which is where the real harm comes. So I think there's a lot of work to be done in that space.
I want to add too, because the pushback, it's healthy. This is a scientific discussion, but there's a process for making these kinds of judgments. And we have a National Academy of Sciences, and they've had committees set up to answer this question about the relative harm of e-cigarettes to combusted cigarettes. And the preponderance of evidence and the opinions that were offered by those committees is, relatively speaking, based on the best evidence we have now and our projections from what we know about the constituents that you mentioned, the relative harm is much greater with combusted cigarettes than e-cigarettes. So that's what the evidence says, and everybody's entitled to their own opinions, and the evidence might change with new products that come on or new evidence that becomes available. But what we're trying to do is represent the evidence as it stands now. So we're not advocates for e-cigarettes. We are advocates, I think all of us probably, for reducing the use of combusted cigarettes. The record there is so overwhelming for decades, year after year. 500,000 people dying in the United States prematurely, horrific deaths from combusted cigarettes. So if some people who are using them can't totally quit nicotine, there appear to be some other products, non-combusted products, that might be able to provide the nicotine without the same level of risk that the combustion produces.
Yeah, and if I can just add, I think you're right. This is, for me, the results are not the end. It's just the next stage. So the goal is all those folks that did get off the cigarette, that switched to the e-cigarette and lowered their exposures. Now we help them quit. So if we had tons of funding to continue on, that would be the next phase of the study, right? The next stepping stone of this study to get them off. I mean, I think about this kind of a personal story. My husband is a veteran and used smokeless tobacco for so long. So I got him to get on, finally, nicotine gum. And while that's like the most safe and approved, you can even have ulcers, acid reflux. There's some challenges with that. And so finally we got him off that, right? And so I view that e-cigarette, while we don't have like the formal fancy designation in a very same way. And so to me, it's really meeting people where they're at. But I would not be able to sleep at night if we were like, okay, now you're on an e-cigarette, bye, right? It's just it's the next frontier.
Yeah, I'm sorry. I have one more question. A bunch of presenters have mentioned like biomarkers of exposure and harm. And I'm wondering, because there are differences between e-cigarettes and cigarettes, if you have new, more effective comparisons, or if you think that those really paint the whole picture, or even like are pointing in the right direction, if that makes sense.
I can attempt. So I work alongside Steve Hecht and Irina Stepanov at the Masonic Cancer Center, who have been studying biomarkers in smokers for a while now and are now starting to do it in e-cigarette users. So the best way to look at is really to getting as most proximal to the biomarkers that really predict disease, like DNA adducts. And so they're doing some of those studies and looking at what actually, how do these, because you can be exposed, but then you can metabolize exposures, you can have DNA repair. And so even though you are somebody that has higher exposure, doesn't necessarily mean you'll have higher risks, although that tends to be the case. And so I would be happy to connect you with some of those ongoing studies that are really getting more at biomarkers that can be shared across products versus some of the biomarkers that we've just developed to be so specific to cigarettes.
All right, thank you.
Other questions, comments, thoughts? Please use the mic. We still might have people online yet.
Just quickly to add on to what you were saying, Steve, is that the National Academies of Sciences, Engineering, and Medicine, that they looked at 800 studies. So it's, they looked at a lot of studies.
There's a reason that we have the academy and those committees, is because these are complex questions and you need a group of experts to sort it out. And so that doesn't mean it's never the final word in science. It's
I would say we have failed at communications and dissemination. And so, I think the science will evolve. And at this current point, I agree with what has been said, but where we have failed is communicating this and making this digestible, engaging, and not saying that it needs to be third grade reading level, but we just know that everyone wears multiple hats. I imagine if you're at a State Department of Health, you are juggling so many tasks and so many responsibilities that, carving through some of these reports would take, days for us. And so I think it just reflects public health has failed at communicating.
Okay, so, please, yeah.
So I just had a question. I know that the studies showed, the reduction of cigarettes per day with an increase in the e-cigarette use, but I'm wondering if you collected any data or have any intentions of looking at like overall nicotine intake or level of dependence, or even quality of life measures like time spent in use or perceived psychological impact, especially for the psych population.
Yeah, those are great questions. And I think, when we're talking about harm, I'm often talking about risk for cancer, physical harm. We're not talking about dependence and addiction. And for some, that can cause a lot of harm and should be addressed. And that is consistent across any nicotine product that could persist. So we do have measures on nicotine intake. I didn't present that today, and I don't know those data off the top of my head, but I can send that to you if you'd like. Yeah. But I think it's an important question that should be addressed in most studies, is the absolute change in nicotine intake, and then the absolute change in overall nicotine dependence across products, because that's something that needs to be addressed.
Were you asking in part about, do we have any measures of mental health adverse effects?
Well, I know one of the randomized controlled trials mentioned a psych population.
Yeah,
Right,
yeah.
so
Yes,
just
yeah.
because of self-medication and if they
Oh,
had
that's
any
right, yeah.
perceived
Oh,
differences.
yeah, we have tracked that, and thus far, we are not seeing any serious adverse effects in terms of recurrence of depression or exacerbation of depression, or we have an opioid use disorder population, and maybe they might resume use in illicit opioids, and we haven't seen any of that, but we do monitor it. Yeah.
And this is, so there have been two of those studies now done. This most recent one, which was published, and then another one published in 2020, and the results are consistent in both studies, same population.
But I mean, that's why we have the grants for the FDA. So Scenic was doing, when you say the general population of people who smoke, you're going to have a lot of these things in that population as well.
Yeah.
A lot of comorbidities, which we've been talking about all day. But our center focused exclusively on people who had to have those comorbidities to get into the study. We're socioeconomic disadvantage. And so part of our charge was to track whether there might be unanticipated adverse effects in those characteristics as a result of lowering the nicotine content in their cigarettes. And then we carried those same measures over when we did the study of adding the e-cigarettes. And so far, we're not seeing any evidence of the kinds of well, we were anticipating them, but if you went, if this policy was implemented, the potential adverse effects, and we're not seeing them so far.
Okay, thank you.
Any other questions, comments? Okay, well then, I think we're good. So, yeah, that brings us to wrapping up and my closing comments. I have to admit, this is conference number 12. And by the time we get here, I'm always so tired that I just say thanks and goodbye. And I tried to do a little better, but I'm tired again. And I would guess I'm not alone in that. So I first just wanted to thank everybody in the audience, here in person and remote. With our administrators, Chris Pung, we have given him a shout out and he deserves another one. Chris, great job. And then, of course, we have administrators home watching, minding the fort while we're all down here, Susan Enos and Danielle Ziller. And so thank you to those two. And then to all the speakers and chairs, everybody has been on time. We haven't gone off. And in the past, we had graduate students and postdocs who would sit in the first row and hold up 5 minutes, 4 minutes. And this year we were a little short. And so we said, I said, I really haven't seen people do that, like go off, go longer than they were allowed and whatnot. So we didn't do any of them holding up the time or whatnot. And I don't think a single paper went over. So, and then the Q&As have been great. So I couldn't be happier. And I'm really thankful to everybody for making it what I think has been a really successful conference. And then I started out the conference, why do we have these conferences so frequently on tobacco, especially cigarette smoking, but and then I listed 4 buckets, if you will. And I have a lot of notes about each one, but it's just for sake of time. I'm just going to say, I think we made substantial progress in each one of these areas. I think you've heard a lot over the last 2 days. You heard me just on my soapbox about the devastating carnage that combusted cigarette and combusted other tobacco use causes. I mean, it's overwhelming. What I am just I find mind-boggling is why we don't do more given the level of carnage. And so that's where I mentioned the insufficient healthcare response. It's sort of like almost at times an indifference. And I was reassured because sometimes I think I'm just getting old and cranky. And I don't want to do that. So I was reassured that I came in, with that bullet, with that heading, and then Nancy Rigotti came in independently and was speaking about the same thing. But Jack Kennyfield was here to be optimistic for us. If those of you who know Jack, he is always optimistic. I've known him for 40 years. I've never seen him not optimistic. So he's always optimistic that we are making progress, and the healthcare community, public health community is trying, but we have to do better. Disproportionate impacts on vulnerable populations. We heard a lot about that over the last 1.5 days, especially today. And so I think we made good headway during the conference on that topic. And the last one, advocacy. So today I think was especially good. I mean, those of us who have knowledge have to speak up because especially now that this problem is represented in more disadvantaged populations who have comorbid conditions, they aren't going to go into legislature and do the advocacy, so who's going to do it? And I think it's on people who have our kind of training, our kinds of background, and others, of course. But I hope all of us will take a little bit more of an inclination after this conference to speak up. Be a little cranky. Yeah, so I think that's all I have to say. I really want to thank you all for, especially those of you who stayed right to the end. It's been terrific. Thanks for coming. Keep an eye out. We'll be doing one of these again next year, I hope. I'm sure we will. And then watch also those who were speakers here. You'll be invited to contribute to a special issue of Preventive Medicine that we've written, that we've edited and published each year. So the one based on last year's conference is coming out any day now. And I'll be inviting papers from this year's conference, and those papers would come out in a special issue probably around fall of 2025. So with that, safe travels. Thanks for being here and have a great weekend.